Now we will be hearing from Dr. Robin Yabroff, who's also from the National Cancer Institute, and will be talking about the MEPS survey.
Thank you, Ashley, and good morning, everyone. I am going to be talking about access to care, expenditures, and productivity in survivors of adolescent and young adult cancers. And I want to emphasize, I'm talking about survivors of adolescent and young adult cancers, not adolescent and young adult cancer survivors. So this is it's a prevalent sample, many of whom were diagnosed many years before the survey. So what we're looking at are things that happened among mostly long-term survivors of adolescent and young adult cancers. Okay, as some of the others have already said, cancer survivors can experience lasting effects of treatment and increased risk for additional cancers and other chronic conditions. And compared to individuals without a cancer history, survivors of adolescent and young adult cancers can also experience greater disparities in access to care and use of preventive services, particularly by insurance type. Greater healthcare expenditures, not only right after cancer diagnosis, at the end of life, but also in the period in between, long-term survivorship. Cancer survivors have greater health limitations, and limitations the amount or kind of work and days lost from work. So less research has focused to date on socioeconomic outcomes of survivors of adolescent and young adult cancers, and the goal of my talk is really to adapt several existing recent studies using national data to focus in on survivors of adolescent and young adult cancers compared to those without a cancer history. I'm going to be looking specifically at access to care, and that includes measures like having a usual source of care, types of preventive services received, and also whether or not there have been any trouble or any problems in accessing care, healthcare expenditures, and productivity losses. That will be health-related unemployment and missed work. The national data source I'm going to be using is the Medical Expenditure Panel Survey, or the MEPS. This is an annual survey with overlapping panel design, and the sample is selected from the prior year National Health Interview Survey. The survey is conducted by the Agency for Healthcare Research and Quality, and it's also nationally representative. And in any given year, it's about 13,000 households and about 32,000 individuals. The average annual response rate in the years that I'm going to be looking at, which are 2008 to 2010, was about 60%. And a variety of topics are addressed, including health status, access to care, health insurance, healthcare utilization, and expenditures. So really it is an ideal source to be looking at some of these outcomes. So I used 3 years of the MEPS Household Component, that's 2008 to 2010. And the question we used to identify cancer survivors was, did a doctor or other healthcare professional ever tell you you had cancer malignancy of any kind? And again, this is a prevalent sample of individuals who have ever been diagnosed with cancer. The sample was ages 18 to 64 at the time of this survey, and cancer survivors were diagnosed at ages 15 to 39, and the comparison group was the group of individuals without cancer. So we looked at the association between cancer survivorship and a variety of outcomes related to access, expenditures, and productivity. We addressed the complex survey design, and we used multivariate logistic regression and controlled for things that were different between the two samples, things like age, gender, marital status, and also number of comorbid conditions. And I'm going to talk a little bit about that at the end, about the decision to control for those comorbid conditions. And what we're reporting are predicted margins. So it's essentially an adjusted percentage that allowed us to control for these variables that were different between the two groups. So this table shows characteristics of survivors of adolescent and young adult cancers. As you can see, the yeah, that looks okay. Most of the cancer survivors, if you look at the groups ages 45 and older, most were at least 5 years after their diagnosis. Again, this is a prevalent sample of cancer survivors. There are some differences in age. Cancer survivors are a little bit older, more likely to be women, more likely to be non-Hispanic white. Cancer survivors were also more likely to have public health insurance and less likely to be uninsured. As Eric mentioned in his study using the behavioral risk factor surveillance system, a lot more comorbid conditions in this population of cancer survivors compared to individuals without cancer. I'm going to take a minute to orient you to this slide because I've got a couple others that look a lot like it, and so I think it'll be helpful. What we did is we stratified cancer survivors and individuals without cancer by type of health insurance. So we've got private health insurance, public health insurance, and uninsured. And what you see is that cancer survivors with private health insurance are a little bit more likely to have a usual source of care. But then if you look at those that are uninsured, a little bit less likely to have a usual source of care. And public health insurance is similar or a little bit less likely in other measures. And these are adjusted estimates. We also looked at a variety of other measures of access, types of care received. And this slide is an example, another type of service, recent dental visit by type of health insurance. Similar pattern for cancer survivors with private health insurance. A little bit more likely to have a recent dental visit, but it's really pretty much the same. But if you look at those with public insurance or those that are uninsured, you see that cancer survivors are less likely to have had a recent dental visit. And we see a similar pattern across multiple types of preventive services. And just to reiterate, the differences you see by type of health insurance are greater for cancer survivors than they are for individuals without cancer. Now I'm switching gears a little bit, and instead of asking whether people have had a service, now we're looking at if they had any problems in getting a service. I want to point out that the scale has changed, and look, this is a 50%. And again, these are adjusted percentages. About 17% of cancer survivors report being unable to get or delayed necessary medical care, dental care, prescription medications, compared to about 13% of individuals without a cancer history. And again, these are adjusted estimates. So when you look by type of health insurance, a similar pattern to what I showed earlier. Among those with private health insurance, a similar proportion report being unable to get or delaying necessary care, but when you look at public health insurance or those that are uninsured, cancer survivors have greater disparities in their ability, saying they're more likely to be unable to get or delaying necessary medical care. When asked if this is a problem, not surprisingly, just about everyone, at least half of everyone says that it is a big problem, but it's a bigger problem for those with public health insurance or for those that are uninsured, slightly greater for cancer survivors compared to individuals without a cancer history. Now I'm going to switch gears a little bit and talk about mean annual expenditures, and this is based on some preliminary work that my colleague Gary Guy at the CDC has been leading, and unfortunately he was not able to be here today, so I'm presenting for him. So we looked at mean annual expenditures, and everything is in 2010 dollars. If you look at cancer survivors, mean expenditure is about $8,300, which is almost double that for individuals without a cancer history. And these are all types of healthcare expenditures throughout the year. But in these pies is a distribution of the types of what the expenditures are for. And one thing that I think is particularly interesting is the greater percentage of inpatient care in cancer survivors compared to individuals without a cancer history. In this next slide, we're looking at limitations in kind of work or activities because of physical health. And the time period is 4 weeks rather than a year in what I showed in the last slide. If you focus on the blue in this slide, you'll notice that about 25% of cancer survivors indicate that they're limited all of the time or some of the time, compared to about 16 or 17% of those without a cancer history. Again, these are adjusted percentages, which control for the effects of age, comorbid conditions, and a lot of other factors that were different between survivors and individuals without a cancer history. In this slide, I'm showing lost productivity across a variety of different measures. The percentage who are unable to work because of illness and injury, almost double for cancer survivors compared to individuals without a cancer history. The number of missed work days among the employed, a little bit higher, pretty similar, but still statistically different, although this is a very large sample. And lost household productivity days. Again, almost 4 times or 3 times as great for cancer survivors compared to individuals without cancer. So what this slide represents is a quantification of the lost productivity I showed in the previous slide. So what we've done is we've taken median wages and applied them to the number of days or hours associated with missing work because of being sick, health-related unemployment, and lost household productivity. So again, cancer survivors, the mean annual lost productivity is more than double that of individuals without a cancer history. The distributions here are pretty similar by the types of lost productivity, although the health-related unemployment is a greater percentage, which is also consistent with what I showed you in the previous slide. So quick summary of my findings, or our findings, that compared to individuals without a cancer history, survivors of adolescent and young adult cancers are more likely to be unable or to get or delayed necessary medical care, more likely to have higher medical expenditures, and they experience greater physical limitations, health-related unemployment, and productivity losses. I'd like to highlight the disparities in access for publicly insured and uninsured cancer survivors compared to those with private health insurance. And also remind everyone that this is a prevalent sample of cancer survivors, many of whom were more than 5 years after diagnosis. And a prevalent sample underrepresents individuals with shorter survival. So if this likely underrepresents what we would see if we were looking at a sample of newly diagnosed individuals. Some considerations to think about when using the MEPS to evaluate outcomes in cancer survivors. The strengths are that it's nationally representative, includes adults of all ages, and it has a comparison group of individuals without cancer. Importantly, for looking at expenditures, it includes expenditures from all payers, including out-of-pocket, Medicare, Medicaid, private insurance, and other payers. There are some limitations with using the MEPS for cancer survivorship, including having a small number with specific cancers or newly diagnosed in any year. Information on cancer diagnosis is self-reported, and so we don't have any information about stage, cancer treatment, duration of treatment, and other information that we would really like to see. Measures are for relatively short periods, and so we don't have long-term trajectories, although if you link information back to the National Health Interview Survey, you have up to 3 years of follow-up for the survivors that are across those samples. So future directions. Many of these have been identified earlier, but I think they are important, so I will go ahead and restate. I think the evaluation of socioeconomic outcomes in survivors with specific cancers, not looking at a group just defined by having had cancer, but the specific type of cancer they've had, and also specific treatments. Ongoing evaluation of access to care and aspects of health insurance with implementation of the Affordable Care Act. I think this is particularly important given some of the disparities in insurance that I showed earlier for cancer survivors. And also investigation of related topics, including financial burden, impact on caregiver and family, cancer-related morbidity and related to access, employment, and economic outcomes and care coordination. Importantly, I think greater utilization of existing data, research resources, novel data linkages, and enhancements are a really important area for future work. The Cancer Research Network is a group of managed care organizations that can address specific research questions collectively, and they have information about individuals under the age of 65. A lot of the work we've done looking at patterns of care is exclusively in the older population, ages 65 and older. So more work with patterns of care and healthcare delivery in this younger population using existing data resources will be important. Also, increasingly, we're seeing more hospital and ambulatory care discharge data linked to registry data. This is typically state-based, but this is an important opportunity to take advantage of resources we already have, particularly in some states where you can identify an individuals across hospital discharges instead of just the discharge itself. It seems like a small distinction, but it allows almost to have a cohort looking at care over time. Novel linkages, multiple pairs in registry. We see this happening in a number of states, but also novel in the way of things that have not been done as much. So for example, I'm thinking of a recent paper that Scott Ramsey and his colleagues did, linking bankruptcy claims to cancer registry and looking at bankruptcy in cancer survivors compared to individuals without cancer. Enhancement of existing surveys. So this is not just this is standalone surveys, but also existing cohorts with surveys. I think there's a big opportunity to add items related to access, productivity, utilization, expenditures. And finally, supplemental surveys, which I'm going to talk about a little bit. So I've been involved for the past 2 years, working with colleagues at NCI, HRQ, CDC, ACS, the NIH, Office of Behavioral and Social Sciences Research, and Livestrong Foundation to create a supplement to an existing survey, which is the MEPS. What we did is we oversampled households with cancer survivors from the 2010 National Health Interview Survey, and importantly, that's the year that had a cancer control supplement. So a lot of extra questions about cancer prevention and control. And then we added a special survey for cancer survivors that has a number of items related to changes in work because of cancer, changes in caregiver work, financial burden, limitations in activities because of cancer. The survey was completed by about 1,500 cancer survivors with a 92% response rate among MEPS participants. The survey, importantly, as Ruth mentioned earlier, was also fielded by the Livestrong Foundation, which had more than 6,000 respondents overall. She focused in on the adolescent and young adult survivors, but 6,000 respondents is a large number. So the MEPS data will be publicly available in September 2013, and the Livestrong Foundation data will be available by application in 2014. And I think this is a really interesting opportunity to try and offset some of the strengths and limitations of these two data sources. One is nationally representative, the other very large convenient sample, but I think there's a lot of opportunity to ask similar questions in both data sources. And with that, I'd like to make sure that I acknowledge my colleagues at the National Cancer Institute, the CDC, American Cancer Society, Livestrong, Agency for Healthcare Research and Quality, and the Information Management Services. So thank you, and I look forward to your questions in a minute. Thanks.